All right, there we go. Okay, so I'm just going to bring up this one slide, and then as I said on Tuesday, I'd like to leave post-traumatic stress disorder for when we return because I'd hate to split it up as a topic. Right, there we go. Oh, okay. So I'm just going to bring up this one slide, and then okay. Don't need a repeat. All right. So again, as the video that we watched, or the documentary we watched on Tuesday, between Tuesday and now, let's kind of go over kind of what it is that anxiety is from a diagnostic perspective, and then we'll go from there. So, just like with all of the other disorders, and I know I've been kind of emphasizing this a lot, is when we're dealing with anxiety disorder is one, it has to last over time. So in this case, for 6 months, in a number of events or activities, meaning that it can't just occur within one context again. So again, it's persistent over time, and it's maladaptive because it occurs in multiple situations. Again, when we look at general anxiety disorders, especially when we're looking at adolescents and children, and they're experiencing symptoms in particular locations, such as school or even at home, then we start to look at the home or the school environment for the issue. And I will admit that unfortunately, there's a lot of professionals, pediatricians, and everything that miss this. So a parent brings their child to the doctor, says they have anxiety. The doctor just kind of takes mom and dad's notes and medicates the child without recognizing that the child only has anxiety at home, probably due to some abuse that is occurring in the home, but the child doesn't want to leave, for example, school. And I've ran into that a lot when I was a director of a high-risk child early childhood education center. That was very, very common in most normal homes. A child goes to childcare, they're kind of apprehensive about leaving mom, but eventually they do, right? But the difference between the children that I worked with and the children that I think hopefully go to the majority of childcares is they started getting anxiety and anxiety symptoms when they knew it was time for the parent to come pick them up. And so in that case, we would look at some type of trauma occurring with the child, okay? The second criteria, the individual finds it difficult to control their worry, okay? And when we say control their worry, it becomes so overwhelming that sometimes this is where people with anxiety disorders will mask their symptoms through drinking or smoking marijuana or taking other types of drugs in order to dampen that worry. And we see a lot of people with anxiety disorders taking depressant medications because that depresses that worry, at least temporarily. And so that's what we mean by difficulty in controlling. They can't control it without either masking it with some substance or finding themselves feeling like they're going out of control. Okay? Anxiety and worry is associated with 3 or more of the following 6 symptoms. And again, just emphasizing it again, persistent over time and cross-contextually. Okay, otherwise we're dealing probably with something dealing with trauma. Okay. And I will say this too, if you'll notice right here, it only requires 1 to diagnose children. Okay. So the first one is restlessness and feeling keyed up or on the edge. And I just want to stop here again because I've been mentioning that anxiety and depression can be misdiagnosed in childhood. And I'm going back to children again. If you remember, when we looked at generalized depressive disorder, this was one of the symptoms for children and adolescents, that they were restless and feeling keyed up and on the edge, okay? And again, being easily fatigued. If you remember, we mentioned that children with anxiety, not depression, are very easily fatigued and want to kind of withdraw from the world instead of being engaged. So, this is what I meant when anxiety disorders and depression disorders often are misdiagnosed among children. Okay. Difficulty concentrating and mind going blank. This again, this one is an unfortunate. Sheila, I'm not sure why. Sheila put in the chat that she can't hear me. Can everyone else hear me? Okay, Michelle.
I can hear you.
Okay.
I can hear you.
Okay.
Now I can. Sorry.
Okay. No worries. No worries. All right. Cool. All right. So, especially with adults, I've been talking about misdiagnoses and everything else. This one is often misdiagnosed with adults who they think has an anxiety disorder, when in all actuality, they have ADHD. Okay, and we went over that disorder, and I've mentioned how we need to look at adults more carefully. And again, I've known lots of adults who had ADHD as children, and now as adults, their doctors and their physicians want to diagnose them with anxiety and give them a mood regulator instead of the stimulant they need for ADHD. Okay, so this is another one that can be easily, again, when we talk about rule out diagnoses, this is a rule out that we have to look at. Okay, and again with the ADHD, we see irritability, and so, and that's why, again, and I'll go back up to here, this is why we have to have, where is it? At least 3 of these in order to diagnose anxiety. But unfortunately, what happens is all too often they look at, the difficulty to concentrate, and you're irritable. You must be anxious. You must have anxiety. When in reality, they should probably look at some diagnostic criteria for ADHD instead. Okay. Muscle tension, and this comes from the physiological reaction due to anxiety disorders. With anxiety disorders, what happens is a disruption of the sympathetic nervous system. The sympathetic nervous system is the system that gets us ready for fight or flight. And when we have anxiety, our sympathetic nervous system turns on. And so someone with anxiety disorders, and we can say this for 5 and 6, okay, is what happens is that they have a hard time turning on their parasympathetic system. That's a system that calms us down. Okay. And so when we're working with people with anxiety, they often have muscle soreness. They often feel very tight, and their muscles are tightened. And I'll say that one of the courses of treatment are things like massage therapy, relaxation therapy, those types of things, because we want to get those muscles out of that zone of being in the sympathetic nervous system. And also on that physiological end, we have the sleep disturbances. This is difficulty falling asleep or staying asleep, very restless and unsatisfying sleep. Again, when we look at the sympathetic nervous system, it was designed for immediate acute dangers, such as a lion coming into our den back in the day, and it needed to respond very quickly. Again, here what we have is a sympathetic nervous system that won't shut off, and so especially at night, it's going to up or be hyper vigilant, because again, back in ancestral times, back in the hunter-gatherer days, night was the most dangerous time to be a human being, because that's when most predators were out. And so our sympathetic nervous system is gauged at making it so we can't fall asleep easily, because it's being hypervigilant and alert. Okay. All right, so we have to have 3 of these. And then we have to, with D, anxiety, worry, and physical symptoms cause clinically significant, this is the distress and impairment in social occupational. So that's the maladaptive aspect of it. The disturbance is not, the disturbance is not attributable to some type of substance abuse, such as a stimulant type of medication, or other medical conditions. And you'll notice hyperthyroidism is listed there as well, but that's another one we notice that could cause depressive symptoms or bipolar symptoms. It can also cause anxiety symptoms. So we got to rule those out and make sure we have the lab tests to explain those. For general anxiety disorder, we also have to rule out panic attack or panic disorders, okay? And again, that documentary went over the difference between anxiety disorders and panic disorders. And they're very two different type of systems. General anxiety disorder, there is a constant feeling of anxiety and stress. With panic attacks, there's a specific trigger that then ignites that panic attack. And I will tell you, for you who will be who want to work in this area and work with people who have panic attacks, those triggers can be very, very, very unconscious. Okay. I remember working with a young lady when I worked in the college behavioral health center that I mentioned, who had panic attacks, and they were ones that, she went to the hospital because she thought she was having heart attack. She had no history of trauma. She had no history of anything else. But when she came to the dorms and stuff, it was the first time she had been sexualized by her male counterparts. And that sexualization started to kind of ignite some anxiety in her, okay, to where just hearing certain male voices at a certain pitch would create a panic attack situation. All right. And so my point behind this story is she came to me feeling like she was going nuts, that she was making things up in her mind. She was doing this. And then, in this situation, we were able to follow her. I had a student assistant who needed some more credit for some classes and stuff. And so I had that assistant kind of follow and notice when she had anxiety attacks or panic attacks. And what that student noticed is there was just this pitch, this certain male voice. It was kind of a bass, but kind of high pitch at the same type, kind of one of those, boys that are just coming out of puberty sound. And that triggered her panic attacks. And so, and that's what I mean, is sometimes these are very just small triggers that can trigger those types of events. Negative evaluation of social anxiety disorders such as phobias. So we need to make sure that the person just is not having a phobic response due to a social situation or something in the environment. Contamination or other obsessive compulsive disorders. So we want to make sure that we're looking at the environments that the person is in, and seeing if they're reacting to uncleanliness, for example, if they're not able to complete their obsessive or compulsive behaviors. Separation from attachment figures or anxiety disorder. We're seeing this. Unfortunately, I think this one needs to be a rule out more and more, especially post-pandemic, because we're seeing a lot more individuals being diagnosed with general anxiety disorder. But when we actually go look at their clinical case, the fact is that during the pandemic, they were in the home with one person, and that person or couple people were the basis of their world for a couple years. And now that we're coming out of the pandemic, we're expecting individuals to get out and go to the office instead of working at home, doing those kinds of things. And there's a lot of individuals who are having anxiety triggers because here their secure base, as you would say, for the last 2 years is no longer there. They have to go into the world by themselves. Okay. And then the other thing is, and this is what we'll get to after spring break, is we need to make sure that it's not due to due to some trauma, and that in multiple contexts there's trauma triggers that is triggering a stress response. Okay. The other things too, and this is why we need to make sure that we're looking at the client very closely and we're doing a good assessment, is anxiety due to weight gain. If someone has, for example, an eating disorder such as anorexia, that can create anxiety in multiple contexts for individuals who are suffering from that disorder. We will get to this other one, physical complaints of somatic symptoms disorder. So what is somatic symptom disorder? Is a disorder where there is no physical reason for the individual to experience what they're experiencing. So someone might think that they have cancer, and in their body they have no physical sign of cancer, but they go through all of the symptoms that a cancer patient goes through. All right, so they go through everything, and even if they don't, in some extreme cases, this is an extreme case, in some cases, even though they're not receiving radioactive treatment, their hair will start falling out, because that's the expectation of someone who is having cancer. So we have to look at that as well. Okay. Perceived appearance of flaws in the body or dysmorphic disorder. This is much related to anxiety or anorexia. Is that, does the person have a realistic view of their body, or are they exaggerating their weight or underweight? Having a serious illness, anxiety disorder, or content of delusional beliefs. When we get back from the spring break, we'll finish with post-traumatic stress disorder, but then we'll get into psychosis type disorders, which are breaks from reality, and we'll see how anxiety can be produced by having delusions or disordered thinking that can be created. So you'll notice that with anxiety disorders, there is a lot of rule out stuff that we need to do. And I think, unfortunately, in our current fast medical world, we don't slow down and look at all the things that are happening in our patient's world to make sure we're actually treating the appropriate thing that we should be treating. Okay. All right.